All right. Hi. So I think, as Joseph said, I'm Jim Cimino, adjunct professor of biomedical informatics at Columbia, and now also director of Informatics Institute at University of Alabama in Birmingham. And this topic, terminological ontologies in biomedicine, is one of the topics that you'll have trouble telling your parents about what you learned in school today. It can be kind of obscure, but terminologies and ontologies are actually important underpinnings of a lot of the things that we do, maybe everything we do in biomedical informatics. So while you may not be able to talk about this at home or at a cocktail party, you'll be able to talk about other things much better if you have a good understanding of one of these foundational principles. Okay, so I'm going to talk about the role of terminology, some of the roles of terminology, and then I want to try to convey to you that there's this notion of good terminologies and bad terminologies, and you can actually tell the difference between them. And I'll talk then more about a formal set of desiderata, or desirable characteristics for controlled terminologies. And we'll do a survey of some terminologies, and at the end we'll look and see how high quality terminologies can help you do some fun things in biomedical informatics. And I'll end with some take-home messages. So this is a list of airports and airport codes, and each of those little three-letter codes is a controlled term in a controlled terminology. And you better be careful when you're picking your airport on Travelocity or wherever to not put in the wrong code, because you'll end up at the wrong airport. So that's one example from every day. Probably none of you remember this. Maybe Joseph does. But this is the C prompt in DOS, and whatever you typed after that was a controlled term. You might say format, you might say run, you might say derf or directory, but those were controlled terms that the computer understood the intention of. And then last, this is a Burger King, no particular Burger King, but it reminds me that I was in a Burger King once trying to get some food, and the person in front of me wanted those little chicken nuggets that you see on up in the corner there, and he kept calling them Chicken McNuggets, and the guy behind the counter kept saying, we don't sell Chicken McNuggets. And he didn't come and say, well, this is Burger King, not McDonald's. We call them chicken nuggets, or whatever they actually call them. He just said, he just pretended he didn't understand. And I finally had to step in and say to the guy, look, this is Burger King. They don't call them McNuggets here, they call them chicken nuggets. And so he got his order. Then he asked me what I wanted, and I told him I wanted a Big Mac. Okay, so here let's look at biohealth terminologies. This is the 2010 census form, and it has on here, somewhere on here, gender. Oh, there it is. The question 6, what is the person's sex? Male, female. So that's the controlled terminology for sex or gender, and that's all you get. You don't get any other choices on the form. This is a set of charges from a medical hospital discharge, and these are controlled terms in a terminology, probably ICD-9 or CPT codes that correspond to actual charges that the hospital will render. And then this is a controlled terminology also. This is a prescription. Can anybody read that? No? Nobody? No nurses in the audience? No pharmacists that can read physicians' handwriting? Okay. So that's Wellbutrin slow release 100 milligrams, number 30. So that Wellbutrin slow release 100 milligrams is actually a controlled term. So even when you can't read it, it might be a controlled term. Okay, so what do these terminologies have to do with health data? They're a kind of special value type. So you may be familiar with value types like integers and text strings. This is a different kind of value type where it's a list of things that you would pick, say, from a pick list. And I'm sure you're familiar with those. Every time you put your address in a website, you pick a state, and that's a controlled terminology. You pick the 2-letter code for a state. This same thing in healthcare. One of the advantages to using controlled terminologies is you can reuse them across different parts of the data set, so you can find the same data, the same information, if it's been stored in multiple different ways using that controlled terminology. It constrains what you can say about the situation, and that can be a bad thing because it can stifle creativity or can stifle expression. But it also can be very useful, because when you limit what you can say, then there's a chance the computer can help you with what you're talking about. But it does provide consistency, whatever else you can say about it. It allows you only a limited number of ways of saying things. If you have a list of 1,000 diseases, that's it. If a patient has some other disease, you've got to find another way to say it. But if it's one of those 1,000 diseases, you don't have to worry about somebody using a different name for the same disease. Okay, so there's a little case I like to use, and we'll just look at a piece of it here. We say the patient is a 50-year-old Native American female, presents to the emergency room with chief complaint of lip numbness, nausea, and chest pain. So there's a lot of information in here, and there's a lot of things that we could put in a controlled terminology, but let's just pick a simple one. We want to capture these data for the patient record, but it'd be nice to be able to reuse them in another system if the system could understand what we're talking about. And one such system would be the admission discharge transfer system, which decides what room the patient goes in. So obviously we want this patient to go into a female room, and so if the system knows the patient's a female, the system can tell us which room to put him in. So this is pretty mundane, pretty simple. The patient gets admitted, we record the gender in one place, and now the computer can do things like remind us about health maintenance. Does this patient need a mammogram? Does this patient need a pap test? That sort of thing. Assigning a bed is a really simple one, but just as important sometimes. So we have our data this way, we put it in our electronic medical record, and rather than re-entering it somewhere else and maybe making a mistake, we can just transfer it electronically and have the systems do the rest. Okay, so how do we do that? How does the computer know the patient's female? Well, we said female in our note, but there are other ways we could say it. So this is one way, but I could also say it with a capital F when I'm typing it in, and although they look the same to us, to the computer, that's a different character string. That F is a different character than that F, and if you don't tell the computer to ignore the case, upper lower case, then it will say, oh, that doesn't match what I'm looking for. But you could also do it that way, or you might do it this way, or you might do it this, and if it's a pediatric case, you might say girl. So there's lots of different ways to convey the gender or the sex of the patient. And the computer has to know what you mean. You can't just put all these in there and expect it to figure it out. So let's look at a couple definitions. First, a term. What I mean by a term, a word or phrase that is associated with a specific concept or meaning. We could also sometimes say a controlled term, but just a term, it's a particular phrase associated with a meaning. A terminology is a finite enumerated set of terms that we use to convey information unambiguously. So it's not just to to limit what people can say. There's actually a purpose, which is this conveying information unambiguously. Okay, terminologies have some basic features. They have a unique identifier, which is a code. It could be the name of the term, but a lot of times it's the code. So if you think about in gender, we might say F is the unique code for that. There's some sort of official name or canonical name. In this case, we might say something like that for female. And then there are synonyms, other phrases or words that somebody might type in. The computer can go, oh, when you typed in woman, I see you must mean female, and I'll store code F in the database. Advanced terminologies have other things. They may have cross mappings between the terminology you're dealing with and other terminologies for things like automated translation. So you might want to have a problemless terminology and then map that to ICD-9-CM, which we'll talk about later. You might have pharmacy drugs, you want to map them to NDC codes. And there are also maybe semantic relationships to other terms, things that convey knowledge about what the term means. So for instance, you might link a drug to its ingredients, which are chemicals. You might link laboratory tests to the substances they measure. So those could be controlled terms as well. And this is a property of ontology. So when we talk about ontologies, we're usually talking about additional knowledge about the terms, not just simply a list of terms or a hierarchy of terms, but something that conveys more meaning. Okay, so ontology, here's a formal definition of ontology, a representation of knowledge, such as a hierarchy within the domain using a shared vocabulary to denote the types, properties, interrelationships, that is, knowledge about the terms themselves. Ontology actually has other meanings. It actually just means a knowledge base when we're talking about computer science. In philosophy, it's the science of what we know, the study of what we know. But when we're talking about terminologies, we're usually talking about knowledge about the meanings of terms. Sometimes a terminology will just have a hierarchy and say, that's knowledge, we've organized it, and they'll call themselves an ontology, and it's hard to argue with them, but usually we mean something a little more sophisticated. I'm going to throw another term in here, phenotype. Okay, this is a different kind of knowledge that may be represented, which is a composite of an organism's observable characteristics. And this comes into play when we're looking at things like medical records where we're collecting lots of information about people and we're trying to figure out what's wrong with them or how to classify them. And when you see in the big data context, you'll often see the term phenotype. So phenotype is a special set of terms that may be represented about patient data. And then there's lots of different terms for terminologies. Whoops, sorry. Go back here. There we go. And I'm not going to go into differentiating these. These are lots of different terms you'll see, from very simple ones, abstraction terminologies, through classification systems, all the way out to the richness of an ontology. But you'll see all these. And the reason I don't want to define them is people define them differently, and there's a lot of overlap between them. Okay. So we're going to do a little exercise, or imagine a little exercise. Imagine that we were going to create a form, a data collection form like the census, to collect gender on information about research subjects, patients, library users, students, whatever it is. And we want to collect information about the gender, but we want something more than male and female, because we need to know some other things about that are conveyed. And if you think about what's in the news today, you realize that gender can be a complicated issue. So the question is, we're going to create a list of codes and we're going to enumerate them, and we want to have one code for every possible answer. All right. So and then we're going to have text strings that correspond to the codes, and then we might want to organize them into a useful set. So that would be our controlled terminology for gender. Okay, so now here's the question. We don't have an audience response system for this class, but let me just see a show of hands. So you guys, I'm going to call on you now. A show of hands. I can see most of you. How many people think we need more than 2 codes for gender? Yeah, almost everybody. Okay. How many people think 3 is enough? How many people? 4. How many is 4 enough? Do you think 8 would cover it? How many people think we wouldn't need any more than 8? All right, now we're starting to get 9. Some people think 9. How many people think more than 10? All right, so now the rest of you are just not lifting your hands up. So, all right. I'm going to go ahead here. I'm going to show you a little terminology that I created for gender. And I'm going to call on you again, because I'm going to tell you right off the bat that I made up this terminology to show you what a bad terminology can look like. So, what's wrong with this terminology? Somebody see a hand there? All the way in the back.
You're conflating things such as gender and age, and also gender expression.
Okay, I heard the part about age. Amelia, can you help me? You're closer to the microphone.
Yes. She said that you were conflating 2 types, gender and age, and you were ignoring gender expression.
Okay.
Incorporating gender.
Okay, so are you guys having an earthquake there? Okay. So right. So I've conflated gender, I've conflated age and other expressions of gender with this terminology. Now, I didn't tell you what this terminology was for. So is this terminology about, I didn't say that this was a genetic gender terminology, but I just wanted to have, if somebody said there's a boy living in the household, I wanted to have a term for that. And if somebody said, well, I'm a male transvestite and that's what I consider to be my gender, I wanted to have an answer for that. And so so you're right that I have conflated things in this terminology, but I actually need that kind of information in here. But you're right that it's confusing. So the intent of the terminology is confusing. What else? There's some simpler things that are wrong with this terminology. Yes. Yep. I can't even you guys are all dark, but you're off to the left there, second row. Go ahead.
Well, there's a male child option. There's not a male child option.
So you said that there's male child and boy. Was that what you were looking at?
No, there's no female child.
There's male child. There's no female child, right? So it's incomplete. And male child, if you see boy and male child, those are kind of redundant, right? So that's a problem. So male child is a little difficult. What else? Anybody else? the sound is difficult, so I'm going to just kind of flip all the cards and we'll go ahead. So I've got male transvestite, and I've classified that as other, but most people would say that that was a male. I've also misspelled the word transvestite, so that's a problem with the terminology. And what else? So I guess I've got the incompleteness of I don't have. If I'm going to have male children, I should have female children. So on. So I've got incompleteness. I've got misspellings. I've got misclassifications, and I've got redundancy. I also, this term other, it's not clear what other means, so that could be vagueness. So those are just some examples of things that you might see that are wrong in a controlled terminology. Oh, there's unknown. Okay, that was the one I was missing. Unknown is definitely ambiguous because it could mean, well, we looked under the sheet and we couldn't tell what the gender was. That happens especially in newborn children. Sometimes the genitalia are not quite fully developed, and until you do a genetic test or some other test, you can't tell the gender. But unknown is often used also because it means we forgot to write it down. So we don't know the gender. The patient has a known gender, we just don't know what it is. So that's two meanings for the same term. Obviously they mean two different things and have been associated with the same code. So that's ambiguity. So what happens if our terminology is bad? We can't record data accurately. The meaning of our data is unclear. Remember, the purpose of a controlled terminology is to convey meaning unambiguously. We can't do that with a messy terminology. We may be doing inferencing. For instance, we may want to say, oh, I'm going to decide whether or not this patient should have a mammogram or a pap test. Well, I better make sure I have the gender correct if I'm doing that. So I might order the wrong test. I might interpret the test incorrectly. And I might offer the wrong treatment. And in the case of this admission, discharge, transfer situation, I might put the patient in the wrong room. So lots of things can go wrong when you have a poor terminology. Now, a lot of people think this is already solved. There's the NIH syndrome, which stands here for not invented here. So a lot of people create controlled terminologies, and then they have trouble getting people to adopt them because the people that would adopt them don't really understand them, or they don't share the same model of representation of the world, and they say, I don't really like your terminology, so I'm going to just build my own. So people build their own. And there are standards out there, but people don't, even then when people want to use a standard, they can't agree on a standard. And we'll look at some different standards later on to highlight that. And then if people use different standards, there are not good ways to translate from one standard to another. And another problem is that maintaining these terminologies costs money. So somebody will create a great terminology, and then they can't sell it because nobody wants to pay for it. They go, why should I pay for it when I build my own? So they give it away, and then it gets adopted, and then the world changes, and the terminology needs to evolve, and there's no resources to do that. So that's a problem. And then sometimes terminologies are created where there are proprietary interests, so that you want to use a controlled terminology, you want to use a standard, other people are using it, but it turns out it costs too much money to use it, and you don't have the money to support that. So that can be a problem as well. The real underlying problem, though, biggest problem, is that it's hard to model these symbols, these terms that we use for representing the world, in a way that actually is usable for representing information about the real world. The gender is an example. What was our model for gender? I didn't really say. Am I interested in the way people appear? Am I interested in the way people think? From their sexual orientation? Am I interested in their genetics? Am I interested in their physical body, what body parts they have and don't have? I didn't say in my model. So unless I model that, it's not going to be clear what my terminology is good for. All right, so a little bit of history, my personal history for me. There was this system called the Computer Stored Ambulatory Record, one of the first electronic health records, developed back in the 60s. And it had a controlled terminology. And when I was at Mass General back in the 80s, they put me in charge of its controlled terminology. And one day, the people who coded the records, the doctor's records, came to me and said, "Listen, we have this record, and the doctor wrote a drug down, and we can't find it in the terminology. So you need to add this term to the terminology." I thought, "Oh, okay." I'm thinking it's probably a new drug. They haven't added it to their terminology yet, but it wasn't. It was Tylenol and codeine. And I said, "You gotta be kidding me. You don't have Tylenol and codeine in there?" And they said, "Well, we can't find it." So I added it in the tree. I went down the tree under drugs, opiates, codeine, and I put Tylenol and codeine under there. The next day, I discovered acetaminophen with codeine. Okay, so that was a synonym of it. It was stored under the acetaminophen part of the tree, and was called acetaminophen instead of Tylenol, and so I couldn't find it. And now I've created a redundancy in the CoStar directory, which was used by all of Harvard. So I couldn't remove it, so I left Harvard and came to Columbia and left them with that problem. But it was a good lesson for me about how terms could be when you try to add terms to a terminology to make it better, you can actually make it worse. I was also working on a program called D-Explain, which maybe they'll talk about later in the class, and that was a differential diagnosis program where you put in findings and it would give you a differential diagnosis. Like, you put in chest pain, you put in sweating, you put in rapid heart rate, and it would say, oh, maybe the patient has angina or myocardial infarction, that sort of thing. And so my job, one of my jobs on this was to enhance the terminology and enhance the knowledge base. And I noticed that certain diseases always came out together. These two diseases in particular, Kawasaki disease and juvenile polyarteritis nodosa, would always come out together. And I thought, gee, that's strange. And when I went to look up Kawasaki disease, or juvenile polyarteritis nodosa, it turned out that was the old name for Kawasaki disease. So we had two diseases in the knowledge base that were actually the same thing. And that's bad because you don't want redundancy in your controlled terminology diseases. But I thought about it and I said, well, the reason we found this is because the descriptions of the disease are the same. So I thought, gee, those descriptions are kind of knowledge about the disease, about the meaning of the term. They're not really describing the disease, but they're describing findings of the disease. And then I started doing cluster analysis of the knowledge base, and I found lots of examples of these diseases that were different names of the same disease, and I was able to use the knowledge that I had, the findings, as a way to discover that. So those started to suggest to me that maybe there was a way to add knowledge to a terminology to use it to improve the terminology. And at about that time, I was at a conference, and this is in let's see, where is this? This is in Switzerland. I'm blanking on the town overlooking Lake Geneva, and there was a conference at this hotel to talk about terminologies. And I met a guy named Jean-Roul Charret who asked me to write a review paper on controlled terminologies. Because people were starting to use these more, they were starting to complain about what was wrong with them, starting to suggest ways to improve them, and he thought it would be good to have a review paper on that. And so this is the review paper, Desiderata for Controlled Medical Vocabularies in the 21st Century. It was written in around 1996, but it took a while to make its way through the publication process, and it came out in 98, just in time for the 21st century. And I don't know if this is on your reading, but it may be something, especially if you're getting more into informatics, that it's worth reading. What this is a 12 different formal statements about qualities of terminology or desirable characteristics. And one important lesson for this paper is that when you write a paper, try to give it a cool title because people will reference it more. This is a very heavily referenced paper, probably because it has that word desiderata in there, and nobody knows what it means, but they look cool if they reference it, and so it gets heavily referenced. All right, I'm going to talk about a few of these desiderata and go through them kind of fast, and then give you some examples, and hopefully they'll stick. And then I'll show you some controlled terminologies, and we can see a little bit where they adhere to desiderata and where they fail. So let me stop there, though, see if there are questions. Okay, you'll get another chance later on. Is that? Nope, not a question. Okay. So the first desideratum is content. Your terminology has to have in it the things that you want to say, so it can't be empty. But it turns out that just adding terms to a terminology doesn't work. That's what people thought back in the 80s and 90s. They said, oh, this terminology is no good. What's wrong with it? Oh, it's missing these 5 terms. Oh, well, I'll add those 5 terms. Now it's good, right? Well, it's better, but it's still missing these other terms and so on. So that people just kept adding terms to it. It doesn't work, though, because then things get messy. They get disorganized, they get redundancy, and it becomes difficult to use them. So the intent, though, of this content is that the terminology should have the breadth and depth. That is, it should cover the domain and provide sufficient detail for the things that you want to represent. And there's also issues around the way terminologies are structured. Sometimes terminologies are structured with, for instance, a coding scheme that's 4 digits long. Well, if you only get 4 digits, then that means you only get 10,000 terms. And so as soon as somebody wants the 10,001st term, there's no room in the terminology. So the structure could limit the size. Similarly, the hierarchy, you might say, well, we can have 5 levels of hierarchy. That ought to be enough. And as soon as you do that, somebody's going to come and try to subclassify terms under your 5th level. So the structure is very important to look at as a way not to limit the content of your terminology. And so the approach, you really need a formal editorial policy and methodology. It can't just be like SNOMED, which I'll talk about a little bit later. People just wrote letters to Roger Cote in Canada, who was maintaining SNOMED, and said, hey, you're missing these terms. And he would just add more terms. There was no policy. It was if somebody suggested a term that wasn't in there, he would just add it. But you need formal policy to decide what belongs, what doesn't belong. And so, for instance, with my gender example, you could say, no, gender is only about this. We're not going to mix in age into this thing. We might make those synonyms, but we're not going to add age terms, for instance. So you need formal policies. The most important desideratum, though, is concept orientation. The notion that the unit of discourse is the meaning, not the term, not the character string that conveys to a human being what you mean, but rather the underlying meaning that's in there. And that's difficult to represent, but that's the thing that you have to keep track of in a good, high-quality terminology. A lot of the other desiderata sort of come from the concept orientation idea, as you'll see. So you don't want to have vagueness. Every term has to have exactly one meaning, no more than one meaning, no less than one meaning. So non-vagueness, vagueness means it doesn't have a meaning. Ambiguity means it has more than one meaning or its meaning is unclear. So you want to have terms have exactly one meaning, and you don't want to have 2 terms in your terminology that correspond to the same underlying meaning. That would be redundancy. So these 3, non-vagueness, non-ambiguity, non-redundancy, flow from the idea of concept orientation. It's okay to have synonyms as long as they are mapped to the formal terms. You don't give the synonyms their own term code. You map them. You may give them a synonym code, but you don't give them their own term code. If somebody says girl and you want to say female child, then the system would say, oh, you said girl, that's a synonym of female child. Related to concept orientation is the idea of concept permanence. That once you've sort of labeled a concept in your terminology, you can't just delete it or change the name of the term or change the meaning of the term in a way that changes its meaning. Because if you do, then you can't understand the data that have been collected with the previous terminology. So you can't, we used to have a term called non-A, non-B hepatitis. Now that's not a term we use anymore, but a lot of people died of non-A, non-B hepatitis, and we were just to delete it from our lexicon, we wouldn't be able to understand past medical data related to those patients. So it's okay to change the name of a term or the term that corresponds to the meaning as long as you're not changing the meaning itself. One example of this would be a retronym. So if we look at transvenous pacemaker, which is a current term, transvenous pacemaker, it used to be that all pacemakers were transvenous. That is, you threaded a wire into a vein to the heart, and that's how you pace the heart. So they were all transvenous. We just called them pacemakers. But then they came up with the transcutaneous pacemaker, where you put a pad on the chest and you can actually pace the heart right through the skin. Those were called percutaneous or transcutaneous pacemakers. So we had to go back and change the name of our pacemaker to transvenous. It didn't change the meaning, it just was a clearer name for the concept. Now, if we have concepts we don't want to use anymore, like non-A, non-B hepatitis, I said we can't throw them away, but we've got to retire them and keep track of them somehow. So we have hepatitis A, hepatitis B, and then we had these people that were sick from what was clearly a viral hepatitis, but it wasn't A and it wasn't B when we did the test, so we called it non-A, non-B. Since then, we discovered a number of different viruses. One of them is hepatitis C. Now, you could just say, well, I'll add hepatitis C as a child of viral hepatitis, but that wouldn't be quite correct. Instead, what you want to do is retire non-A, non-B and make hepatitis C a child of that retired term. Because now, if you say, get me all the patients with non-A, non-B hepatitis, you would find all the people with that code, but you'd also find the people with hepatitis C, which would be classified as a non-A, non-B hepatitis. So that's a kind of a complex way of representing the notion of retiring terms from a terminology. It's hard to do, but if you do it right, it can be very valuable when you are querying for data across data sets over time. All right, number 4, non-semantic identifiers. This is pretty straightforward. I said that we have identifiers for codes, and sometimes people use the name. Don't use the name. Don't use the name for your control term. It seems really tempting. Why don't I just use the code female when I mean female? Then I can read it, the computer can read it, we're all good. The problem is that you might decide to change the name of a term to correspond to a meaning, to clarify it, and now you've changed the code, effectively changed the code for your concept. So you have an old code and a new code for the same concept, and that's redundancy. So you don't want to use the name. You also shouldn't use a mnemonic. That's very tempting as well, to use a code like Gluck for glucose. So yeah, why not? What's the problem? I got to use something. Gluck is nice and short. I'll only use it for glucose. Well, the problem is people do that and then they run into trouble. They don't remember the mnemonic despite the name, and they create a different mnemonic for the same thing. Or the mnemonic becomes ambiguous because you can't tell is Gluck glucose or is it glucagon or something else. The best thing to do, and don't use a code that'll run out of room. I mentioned the 4-digit codes. Don't use a code that'll run out of room. And also, don't use a hierarchical code. Don't use a code, that's very tempting too, and I'll show you an example when we get to the ICD, where you use a hierarchical code just so you can show where the term is in the hierarchy, and then you run into trouble later on. So the best thing people do now is use a meaningless integer. That is, the integer doesn't have any particular meaning by itself. It's just the next term. Oh, I've got 1,000 terms in my terminology. I'm going to add one more. Well, the code is 1001. That's all it means. And I might add a check digit. And a check digit is a calculation, the result of a calculation performed on the integer. So, for instance, you might say, add up all the digits in my integer, and then take the if that has more than one, if the sum has more than one digits, add those digits together. And keep doing that until I have a single digit, and that's my check digit. And your credit cards have check digits on them. And what those do is they say if somebody types in the whole number and the check digit doesn't match the mathematical function on the rest of the number, then the computer could say, hey, there's something funny about that code. It doesn't. There's an error. You've transposed 2 digits, or you've left out a digit or something. Typo or something, but there's a problem with it. So a check digit's a useful thing to add on, and we'll see an example of that when we get to LOINC. Next one is polyhierarchy. So I talked a little bit about hierarchies, and I had a hierarchy in my gender terminology. A polyhierarchy goes under a number of different names that are shown there. All they really mean is that a term is allowed to have more than one position in a hierarchy. It can have more than one parent. Okay, so you don't want to have cycles in your hierarchy. That is, you don't want something to be its own grandchild, things like that. But things can have more than one parent, and that comes in handy for lots of things in biomedicine. It helps us understand the meaning of a term when we see where it's located in a hierarchy. It also helps us for tree walking. If you remember my example of Tylenol and codeine, the reason I couldn't find it is I walked down the tree, I want drug, opiates, codeine. Hey, where's Tylenol and codeine? Well, it was in the other part of the tree. It was on drugs, analgesics, and acetaminophen, and it was under acetaminophen and codeine. So if it had been in 2 places, which is not allowed in the CoStar directory, if it had been in 2 places, I would have found it either way in walking down the tree. And then finally, related to that is the need for inferencing. So that if I take my example of Tylenol and codeine, and I say, and I have say an alert in my system that wants to say, well, is the patient on any opiates? Well, if the drug is classified as an opiate, that's great. But if it's only classified as an acetaminophen, and it'll say, nope, patient's not on any opiates, so you go ahead and give another opiate. And that could be a problem, obviously. So inferencing, that classification is often used for inferencing and things like decision support. So here's an example, Goodpasture syndrome. Goodpasture syndrome is a disease, an autoimmune disease where you produce antibodies to a protein that's in the basement membrane of the lung and the kidney. So this protein is in 2 different places, and you develop antibodies, and so you actually have a disease that affects your lung and your kidney. So in a strict hierarchy, you have disease, you'd have heart disease, lung disease, kidney disease, and then you got to decide, where do I put Goodpasture syndrome? I'll put it under kidney disease, that's true, but then if I say, does the patient have lung disease, it'll say, no, I don't see any lung diseases because Goodpasture is not classified that way. So in a polyhierarchy, we would do it like this. So we have something that has 2 parents. And some people object to this, and they have really good reasons for objecting to it, none of which are grounded in reality. Because when you get to the real world, you just find that there's no way around this multiple hierarchy arrangement. While we're looking at diagrams, let me show you a different one, the semantic network. Some of you are probably familiar with this. Here we have hierarchy, and it's represented with ISA, and the arrows, notice the arrows point up, because we'd say good pastures is a lung disease, good pastures is a kidney disease, and it's apparent that's the hierarchical part. But we can also include non-hierarchical links that have meaning or semantics. So for instance, lung disease has site lung, and kidney disease has site kidney, and good pasture syndrome will inherit both of those through the semantic network. Similarly, there's findings like hemoptysis and hematuria. Lung disease and kidney disease don't all have that, but good pastures does. So we can provide that kind of information as well. So that's a semantic network, and we'll see some examples of this later on. Let me stop there, see if I lost anybody. Questions? Okay, there's a, okay, I mean, yeah.
Network. So I had them say you use a complete hierarchy network, then you'll help you to narrow down. You want to find a specific piece throughout the hierarchy. So, but is it possible for you to do it to the same like searching and narrow down or filtering things through this hierarchy?
Okay, I'm sorry, I heard about every other word of that. So somebody close to the microphone could repeat the question for me? Oh, that'd be great. Step up so I can see you.
Okay. Oh, hi.
Hi.
So basically, I was just wondering, for the polyhierarchy network, I can understand that if it worked that way, it's possible to narrow down the system. It's like I can basically filtering throughout different hierarchies. And is it possible to do the same thing for semantic network, because system's sort of flat for me?
Oh yeah, no, that it was. You can certainly do that. The is a hierarchy is part of that. Typically, a semantic network will have a hierarchy in it. But then you could say, find me all the terms that have find me all the disease terms. So everything in the hierarchy, the disease hierarchy that has a site lung. So you could actually find that. And actually, one of the I'm going to get to this in formal definitions. But by having that kind of knowledge in there, you can write queries like that that'll help you improve the terminology. Because you could imagine if I have a disease that has the site lung that's not under lung disease, I might go, hey, maybe that belongs under lung disease and I should classify it that way. So you absolutely can do those kinds of queries.
Okay, thank you.
Yeah. Good. Thank you for your question. Other questions? Anybody else need to stretch their legs? Okay. All right, let's go. We just got a couple more to go. So formal definitions. A formal definition is something that conveys the meaning, but it's structured and controlled. That is, it has a defined way to arrange terms that define the term in question, and it uses controlled terminology, not narrative text, to express the meaning. So it helps us support understanding, and as I mentioned just now, it can help support maintenance, because you can use that information, that knowledge, to actually audit the content of your terminology and say, wait a minute, this term has characteristics that should place it in another place in the hierarchy. Is there something wrong with my knowledge, or is there something wrong with my hierarchy? And so it's represented through relationships within the hierarchy, and you could use something like a semantic network, for instance, to do that. The knowledge that we represent is typically definitional information, things that are pretty stable. You know, the site of the lung is going to, the site of pneumonia is going to continue to be the lung for a long time. Okay, and so we don't have to worry about that changing. The treatment for pneumonia changes all the time. So while that's important knowledge to maintain, an ontology typically maintains the stable definitional information rather than things you assert about the terms in your terminology or ontology. So here's an example of a narrative definition of a serum potassium test. Pretty simple, a test that measures potassium ion concentration in the serum. Here's a formal definition. So serum potassium test, a controlled term. Is a controlled term for the hierarchical relationship, and it's under the class test, another controlled term. And then similarly, we have has specimen, serum specimen, measures substance, potassium ion. So we have a terminology of chemicals, we have a terminology of specimens, and we have a terminology of tests. And you could also imagine having a terminology representation of serum specimen, which has some representation or relationship to the term serum, another which is an anatomical concept. So that's a formal definition. And then you can depict that. It's depicted graphically if you wanted to look at it that way. Okay, this one, not elsewhere classified. NEC is a term you often see in terminologies like ICD-9 and others, and it basically means other. It means I have a term that I want to say, but it's not classified in the terminology, so I need to use this sort of catch-all term. So the desideratum is don't use NEC terms. Don't include those in your terminology. The reason for that is that so these are concepts. They're used for concepts where you don't have an explicit code for the concept. And the problem is you can never have a formal definition for this thing, because the definition would be this is everything that's not somewhere else in the terminology. And it gets pretty confusing if you have two of those, and which one, what do they mean? The real problem, though, is that when you classify something like this and the terminology changes elsewhere, well, now you've changed the meaning of not elsewhere classified because you've added something. And I give you a nice graphic example of real data. So when I was at NIH, I built a repository of controlled terminology, and I had data from 1976 to 2015. And I looked in 2007 for cases of shock. So the non-traumatic shock, the kind that occurs from things other than car accidents and that sort of thing. So if you had cardiogenic shock, you would use the code 785.51, which was the ICD-9 code for cardiogenic shock. But if you had septicemic shock, you would use the code 785.59, which was shock without mention of trauma, not elsewhere classified. Similarly, if you had hypovolemic shock, you would use that same code because there was no code for hypovolemic shock. So now you have two terms, very different things, septicemic shock and hypovolemic shock, mapping to the same code. Well, in 2008, ICD-9-CM added 785.52. I don't know what it took them so long because this terminology was created in the 80s. But we have septic shock, 785.52, and now I can code those as three different codes. So hypovolemic shock gets its own, still is under 785.59. Then I said, okay, what happened? What was the appearance of these codes in my database? So I asked for the number of codes in the database, and these are actual counts that have been adjusted for some variations of coding techniques, but they're basically the number of cases that I saw in each year. So you look at 2006, 2007, you can see that 785.59, which was probably septicemic shock cases, it was the shock not also classified. You can see there was lots of cases of those, and then in 2009, 8 and 9, it dropped to almost zero. So hey, we're winning the war on shock not elsewhere classified, right? No, not really, because what happened was, in 2008, we started coding the septicemic shock this way with this other code, and so now we see it's been sort of removed from the population. And there's a thing called the Will Rogers phenomenon. During the Great Dust Bowl era in the 40s, when the Okies moved from, was it 30s? 30s, I guess. When the Okies moved from California, Oklahoma to California, the IQ in both states increased. And so Will Rogers was basically saying all the dumb Okies moved to California, so that raised the IQ in Oklahoma because the dumb ones left, but they were still smarter than the people in California, so it lowered the IQ, or raised the IQ in California. Anyway, this is the kind of thing you can do with statistics, and when you have a terminology that has this kind of not elsewhere classified, the meaning of this red line has changed, and that's because of that not elsewhere classified. Okay, so where are we with these? If we look at terminologies today, every terminology tries to cover content. And so they mostly do a good job, and we'll revisit these later. They do a pretty good job. And most terminologies today have embraced the idea of concept orientation and concept permanence. That is, that these terms have a meaning that should not be changed. The notable exception is ICD-9, ICD-10, the International Classification of Diseases. Non-semantic concept identifiers, again, most are doing that. Some have polyhierarchies. Most do not have formal definitions. That's a lot of work to create them, so they haven't done that. Most are rejecting not elsewhere classified. So we're getting there. And if you're interested in the rest of these, there's 5 more in the paper that are a little bit hard, a little bit more obscure. But these are kind of the everyday things that you'll run into in controlled terminologies. Okay, so I have this case, and we're not going to go through the case in great detail, but it's my 50-year-old Native American female. It's got her history or her immediate presentation, and chief complaint, and then past medical history, things she's on some capsules, she's got hypertension, she had a biopsy that had some kind of diagnosis, and so on, allergy to bufferin. And so if we were to try to code data from this story, we would pull data from different terminologies to do different parts of this story. Here's another part of the story. Here's the physical examination and the and other tests that were done, laboratory tests, cardiogram, chest x-ray, and so on. All of these things are things that we could represent with controlled terminologies, and then the computer could help do things with that information. And then finally, the last part, some little snippets of data from the patient's hospitalization. Okay, so all of that is kind of the broad spectrum of data that we might represent on a patient. Okay, so what do we do with this? Well, we might want to find out what the patient is on. It said it was on a capsule that was half blue, half green. So that's pretty vague. But obviously, it would be important to know what that medication was. So we want to be able to go to some ontology that would help us understand that. We might want to get this patient's records from another institution, and we need to make sure we get the right records. So how do we know we're getting the right person's records? How do we keep the clinicians from getting overwhelmed by all the data that we collect and we put it into this big electronic medical record, and now somebody has to go in there and figure out what's the important stuff and what's the stuff that's not so important. She had an allergy to bufferin. Okay, bufferin. Well, what is she really allergic to? Is she allergic to the brand bufferin, or is she allergic to some ingredient in bufferin? And if you want to know what that is, you have to know what the ingredients are, so you don't give her a different drug that has the same ingredient. We want to retrieve relevant evidence from the medical literature. So information from her record could actually be used to search Medline or some other resource like DExplain. It'd be great if we could get the terminology that's in the record to match the terminology that's in those resources. So that there's the example of DExplain, the expert system. This patient might have genetic predisposition. So now we have to start looking at the patient's genome and figure out how that maps to their phenome. And then what we might have to report, in this case it was a case of food poisoning, we might have to report that to the public health department. How do we do that? What terminology do we use to do that? And then we can take that record, and we can learn new knowledge from this record. So the next time somebody comes in with these symptoms, we might recognize it more quickly as a sign of food poisoning, complicated by a myocardial infarction and so on. So that's what when people talk about the learning health system, they're talking about getting knowledge from the record to develop, or information from the record to gain new medical knowledge. Well, it's really hard to do that with just free text and stuff that people just make up and put into a record. You need some kind of controlled terminology to do that. So why is it all hard to do? So it's hard to do, I think. The desiderata are some examples of the things that if you want to do this right, you have to start with high quality terminology and impose some of these things on your terminology that are hard to do or laborious but worth doing. All right, so I'm going to stop there. We're going to talk about some specific terminologies and see where we go with that. So, questions? Okay. So, if we had the chief complaint, we looked at the chief complaint. The patient has lip numbness, nausea, chest pain. We've got past diagnosis, things like this. We might want to code those in something like ICD-10-CM, which you may have heard about. It's in the news because doctors and hospitals are going to have to start coding with this October 1st. And it's a completely different terminology than the one that they've been used to using. And it's going to cause all kinds of turmoil. It's maintained, the original terminology is maintained by the World Health Organization as a strict hierarchy. It does not have complete names. It's got the names sort of, you build the name as you go down the hierarchy, and the code for it determines its place in the hierarchy. It has things that have this NOS or not otherwise specified. That's actually okay. That just means we didn't provide, there's a term there like pneumonia with no more specific name after it, but it also has the dreaded NEC. In the US and other countries, they extend ICD with what they call clinical modifications. So ICD-9-CM, ICD-10-CM, these are terminologies that have additional levels of detail from what the World Health Organization provided. ICD-9, for instance, was created in 1979. ICD-9 was 1975, and in 1979, the US Department of Health and Human Services added ICD-9-CM. So it added almost doubled in size from ICD-9. ICD-10 came out actually in 1992, and we still haven't adopted ICD-10-CM, but we're going to do it. I think we're going to do it this year. And we'll see. ICD-11 is actually in development already, and probably will be starting to get adopted by some countries before we've fully adopted ICD-10. This is just an example of ICD-9 from the book, and you can see sort of these short names. It says, it says other bacterial food poisoning there. Sometimes you'll just see, it'll say the organism, and you have to realize that you're in the hierarchy, the food poisoning hierarchy, to understand that it's a food poisoning. So the ICD terminologies are a way to look at the advantages of hierarchical coding and the disadvantages of hierarchical coding. So if we look at ICD-10 and we look at tuberculosis, we could see, for instance, A15 is respiratory tuberculosis, and then A15.0 is tuberculosis of the lung, A15.4 is tuberculosis of interthoracic lymph nodes, and so on. And we can see all these A codes, A15 through A19, and we say, gee, if I wanted to find all the tuberculosis, all I have to do is actually look for all the codes that begin with an A1, or maybe at least A15 through A19, and that seems really appealing, because now I don't have to search for every one of these codes. I just search for the beginning of the code, and that's the whole idea behind the hierarchical coding system of terminologies like ICD-9 and ICD-10. The problem is when you have something that should be coded in two places because of a polyhierarchy, you can't do it with a hierarchical coding system. So, for instance, you'll see that the sequelae of tuberculosis are elsewhere under B90, and you go and find tuberculosis complicating pregnancy. That's under O980.11 and so on. These are clearly tuberculosis cases, but they're classified under pregnancy complications. And then there's a few others kicking around there. So you can't just use the hierarchical code. You'll miss a lot of cases when you do that. All right, so why do we want to use these control terminologies? We want to record information at a clinically relevant level of detail. We want the meaning to be clear, and we want to be able to reuse the data, recoding the data if necessary, into a different terminology. So we want to be able to, we record what we mean, what we observe, and then if we have to represent it in some other terminology, we can recode it for billing purposes or what have you. So terminologies, variant suitability. So ICD-9, ICD-10 are great for billing. That's how you're going to get reimbursed. They are not great for patient care. So if we record data in ICD-10 and then we try to use it in a decision support system, it's not going to work. On the other hand, if we record data in something that's useful for decision support, we can usually recode it for billing. And that way we only had to code it once, and then we can let the computer recode it to other forms. So ICD-10-CM, the question, there's a lot of hype around it. It's supposed to be so much better. And when I look at it, I see that it still doesn't capture clinically relevant detail. It still has NEC terms. And when you look at the desiderata, at least the ones we looked at, it actually doesn't cover the content because it doesn't have diseases not elsewhere classified. So if you have a term and you don't know whether it's the right side or the left side, there's no term for left side of body not specified. So you end up with these being unable to code things in ICD-10. You can argue all day about whether it's concept-oriented or not, but it does not adhere to concept permanence. There have already been updates to ICD-10 where they've changed the name of a code in a way that changes its meaning. So they don't adhere to concept permanence. They still use hierarchical identifiers, and they still don't have multiple hierarchies, and they don't have formal definitions. So it doesn't do very well in this. And when I've given talks on this topic, and people from the World Health Organization were in the room, they always leave before we get to the question and answer period because they don't want to have to answer questions about why they don't adhere to the desiderata. And they still have the not elsewhere classified. So a different strategy: capture the original text, record that text, whatever the doctor or the nurse or the patient said, and code it with a suitable terminology, something that has the right level of detail, something that adheres to the desiderata. Allow free text modifiers. So if they're coded, if the level of detail you want's not there, modify it with free text modifiers. So that if somebody says, well, they have a fracture of the right wrist and you only have fracture of the wrist, record that word right because it'll be useful later. And then map to the terminology or whatever you need. And then that way, when there's changes to ICD that impact billing and reporting, you can just recode the data in the new version and you don't have to worry about it. A terminology thesaurus, and we'll look at an example of that, is one way to approach that. It's something that brings multiple terminologies together in one place. All right, I'm going to go on. I've got about, well, we're going to have to skip some of these terminologies, I think, because I want to get to the Unified Medical Language System. So I'm going to go very quickly. We're going to look at drugs. One terminology for drugs is the National Drug Codes, which you'll see on your prescription bottles. And that's created by the U.S. Food and Drug Administration. And it has 3 parts to the code. There's a 4 or 5 digit code that corresponds to the manufacturer or the labeler. There's a 3 or 4 digit code that is set by the labeler, and it has to do with the ingredient. And then there's the labeler also creates a 2 digit code. And so you see something, so these codes can be reused, which is a problem. The labeler can say, well, I'm not going to make this drug anymore, but I'm running out of codes, so I'm going to use the old code for a new drug. But then the old drug and the new drug may still be on the pharmacist's shelf with the same code. Obviously a problem. Here's an example of one drug. This is nitrostat, 0.3 milligram tablets, and it comes in a bottle of 100. So there's the labeler code, the product code, and the package code. So it really comes out like this. And what happens is people look at that, and then when they're putting it in a computer, they go, oh, I don't really want the hyphens there. That screws things up. So let's get rid of the hyphens. Well, when you do that, now you can't tell if the hyphen belonged here or if it belonged here. And then worse, they say, you know what, that looks an awful lot like a number. If I remove the leading zeros, now I have a number, and my web browser can tell me whether or not somebody entered a number, and I can make it really simple. But now you have all these different codes, ways to expand these, and each of these could be legitimate NDC codes. So that's a problem with their coding system. I just throw this here for people that want to look at it. This is the NDC code directory at FDA site, and there's a URL for it. A new terminology that's emerging as a standard is RX norm. Started with the notion of clinical drugs from HL7, and it was picked up by the Food and Drug Administration, the VA, and the National Library of Medicine, and drug knowledge base vendors came together to develop a single terminology they could use to code the terminologies used by each of these different organizations. So it uses a semantic network for representing its information. Here's a drug, diazepam 5 milligram oral capsule, Valium. Okay, that's its unique identifier, meaningless identifier. Here's a synonym, and we could see that it has a broader relationship to diazepam 5 milligram oral capsule. So this is a more generic version of this. This has Valium, and it turns out there are actually 2 different drugs that have brand names. One's called Valium, one's called Solus, and they map to this concept here. And then there's also Valium oral capsules, diazepam oral capsules, and so there's all of this hierarchical information. And then there's also non-hierarchical semantic information that tells you more information about the drug. So these are all unique identifiers for control terms in RX norm. LOINC is a terminology for laboratory, typically for laboratory. It's called logical or objects or identifiers, names, and codes. But the L used to stand for laboratory, and that's really where it shines. The idea was to help with HL7. When you have an HL7 message, the code, you want a standard code for your lab test, and this was the intent to provide that code. Just show you some examples. It has the code actually the terms actually have 6 parts. There's the component, which is the thing that measures. There's the property, which is the aspect of what it's measuring, the concentration or the number. There's the timing of the test. Was it a point in time or a 24-hour test? There is the system, which is the specimen, like serum or urine. And then there's the scale. Is it quantitative, qualitative, and so on. And then sometimes the method is included. Is it a finger stick? Is it a laboratory analysis? If it's needed for differentiation. These first 5, though, are mandatory, and the 6th one is optional, and then it's got all kinds of other stuff in it. These are just some examples. There's a meaningless integer. That's a check digit. And then this is a glucose challenge test. Here's the component. Here's what it measures. There's the system. The property. This is substance concentration. Whoops. Point in time. And then the system is Searplas, and it's quantitative. Here's a slightly different one. This one is mass concentration, so it's grams per deciliter instead of milliequivalents per deciliter. And it's got a different code, meaningless identifier, and there's its check digit. And then here's some other things. This is a test that measures the time of coagulation. Here's one that's actually a calculation. And then here's one that actually has a subtype creatinine kinase.mb, which is a subtype of creatinine kinase. So just some examples to show to you. And here you can go to the NCI term browser and look up LOINC and the URLs for that. Okay. Well, one terminology you'll hear a lot about is SNOMED. So SNOMED is the systematized nomenclature of medicine. It has a long history that I won't go through because I'm running out of time. It's actually maintained by the International Health Terminology Standards Development Organization. It used to be maintained by the College of American Pathologists. And a very quick story, this is where the College of American Pathologists had the meeting where they decided to adopt the desiderata for using this desiderata for SNOMED. And the reason they adopted the desiderata was less because it was an important thing to do and more because they wanted to end the meeting and go out to the beach. This is in St. Croix. And they put it as the last thing on the agenda, and the fastest thing for them to do was just approve the adoption of the desiderata. So that's why the desiderata is there. The College of American Pathologists turned it over to IHTSDO, which is in Denmark. So now they have meetings in places like this. It's a little less pleasant. Okay, maybe that keeps them from making rush decisions. I don't know. Here's an example of SNOMED, pulmonary tularemia. It is a tularemia. It is a bacterial pneumonia. It adheres to the desiderata. It's got formal definitions. They got rid of the not elsewhere classified terms, and so on. So it's pretty rich ontology. And you can explore that also at the NCI term browser. Here's just another browser if you want to try a different one. Okay. All right. What do we have left? Okay. The medical subject headings. So that's maintained by National Library of Medicine. Just give you just a little example of that. So here's what pneumonias look like, and it's pretty limited. You wouldn't want to classify patient diseases by this because it's really a very limited terminology, but it's good for retrieval, excellent for retrieval of the medical literature. And there's a site where you can look up mesh terms at the National Library of Medicine. All right. So the last thing I want to mention is the Unified Medical Language System, and we really need about a half an hour to go over this. I'll go back here a second. Previous, come on. There we go. It was actually developed in the mid 80s, and the first version came out in 1990. Don Lindbergh put this in a paper in 1993 that the idea of the UMLS was to understand biomedical meaning in user inquiries and help retrieve machine-readable information. That was a pretty lofty goal, and the way they approached it was to take all the controlled terminologies they could get their hands on and merge them into a single thesaurus, and in which terms with the same meaning were mapped to the same concept identifier. So they attempted to create a single unified terminology of all these other terminologies. And they had some partial success, but it's a tough job. The idea is you could take a string, two strings from the same from different terminologies, and if they have the same meaning, map them to the same concept. And then if a string in one terminology has a relationship to a string in another terminology, then you could say that those concepts were related to each other. So you could create concepts here. And this is just, you can look at this at your leisure, but this is the number of terminologies, just going back to 1999, the number of strings and the number of concepts they mapped it to. So roughly 4 strings mapping to each concept, and 174 concepts in the first version of UMLS this year. Okay, these come in big ASCII files. They're actually pretty easy to deal with. This is Mr. Conso, which is a metathesaurus relational format. It has concepts and sources. So just to give you an example, there's a concept identifier, or CUI. There's a lexical identifier, or LUI. There's a string identifier, or SUI. And they really talk like LUI, CUI, and SUI. And then you can see the name of this. This is the name in the metathesaurus. Here's the name of this thing in ICD-9-CM. Here's the name for it in SNOMED. Here's an English one. Where's the read codes? The benign tumor. Here's one. Here's another one. This is the read code. Sorry, where they spell tumor this way. And then there are other languages, German and Spanish and so on. And this is just a big ASCII file with these vertical bar delimiters, so it's pretty easy to get at this data. Don't really have time to go through the model. So I'm just going to skip through here, but and then this is another ASCII file called MRREL. It's metathesaurus relationships, and we can see that our CUI for benign tumor of the heart is related to things like heart. And where's the code for heart. And we've got the location of, so this CUI is related to this CUI, and this is the CUI for heart. There's a semantic network. It's got 135 semantic types in it. They're arranged in a strict hierarchy, and they are related through 56 potential semantic relationships. And here's a record from the semantic relation definition file. And again, just a very simple ASCII document. And then there's also, here's Mr. Stye, there's a sample of the semantic network concept for my benign neoplasm of heart example. And there's a browser for the UMLS. Not a terminology. People that call it a terminology will be corrected, even by the National Library of Medicine will tell you it's not a terminology. It does not have a formal conceptual model. It does not have a single hierarchy. It's got lots of redundancy, lots of ambiguity. They're always trying to clean it up, and if you find problems and report it, they will fix it. But it's really, the problem is that these terminologies, whoops, again, I got ahead of myself. The terminologies that were put in there don't all have clear hierarchies, and they have ambiguity and redundancy. So they've really, they've done their best to try to make bring some order to all these terminologies. So this is the claim they made 5 years later, which I think is true. The UMLS supports development of user-friendly systems, effectively retrieve and integrate relevant information from disparate machine-readable sources. And that's Betsy Humphreys wrote that in 1998. And that's true. So what can you use the UMLS for? It's really good for finding all these terminologies. It's got 174 terminologies in there, and you want to find one, that's a great place to go to pull them out. Very easy to do. It's great for finding synonyms in your own term. If you have a favorite terminology and you want to beef up the synonyms, you use the UMLS because it's got all these mappings to other terminologies that can act as synonyms. And to a certain extent, you can do automated translation from one terminology to another. Okay, so I think we're out of time. We got 5 minutes left, I think, by my clock, so I'm going to skip the last parts here of why you want to do all this and just show you a couple of tables at the end here. And we'll skip the quiz too, because you guys, I'm sure you don't want to do the quiz. Those will be on the test. All right, so there's a couple tables at the end that you may find useful. So I've got some terminologies here, most of which I talked about a little bit. And then I've got the desiderata here: concept coverage, concept orientation, concept permanence, non-unique identifiers, multiple hierarchy, and so on. And you can see which terminologies do a good job, they get a plus. Which terminologies do a poor job, they get a minus. And occasionally you see a plus minus because they kind of do it a little bit. So ICD, for instance, has a hierarchy, but it doesn't have a polyhierarchy. LOINC has some hierarchy, but it's not well defined, and so on. And if you look at SNOMED does pretty well. It hasn't gotten the definitions finished, but they're working on it. So I give them a plus minus, but they're getting close to plus. And UMLS does pretty well in some of the things, but it doesn't have the formal definitions. It has hierarchical relationships from different terminologies, but it doesn't have a single unified hierarchy, because if you do that, you actually end up with cycles, because one terminology will say A is a parent of B, and another terminology will say B is a parent of A, and you end up with these cycles in the UMLS. And then if you're looking for different areas of the medical record to code, history of present illness, past medical history, and so on, here are my recommendations for which terminologies you would use. One means that they touch on the domain, but I wouldn't use them. Two means they try to cover it. And the three means they really do a good job of covering the domain. And again, you can see SNOMED is pretty good. So if you took this table and said, well, what am I going to do if I want to do the whole record? I'd like to use one terminology. Well, labs is not going to work so well. Diagnostic tests doesn't work so well. But you can use LOINC for your labs, and you can use, there's not a good one for diagnostic tests. Medications, though, you could use NDC or RX norm. And so really what most people would say today is, for coding healthcare data, use SNOMED for everything except labs, use LOINC for that, and then use RX norm for the medications. Okay, so our last slide. So there are high quality, low quality terminologies. I think we could see a couple of examples at least of where ICD falls short because of its failure to adhere to the desiderata. Size isn't everything. Just making a big terminology isn't the answer. Structure is important also. If you have a poor structure, it's going to limit what you can say. And maintenance, which we really didn't get into, but maintenance of these terminologies becomes extremely important because a terminology is outdated almost immediately. If it's a drug terminology, a month later after you make it, there's going to be drugs that you're missing. So maintenance, how you maintain a terminology to maintain its quality is extremely important. It's about the meanings, not the names. Concept orientation is the key point. A lot of these terminologies are catching on, some are not, but we're getting there. And I think the Office of the National Coordinator push for adoption of these standards in electronic health records is helping. So use discipline when you're choosing a terminology for a certain purpose. Look at the terminologies and look how they do with respect to the desiderata. Pick a high quality one. God forbid you have to create your own control terminology. Look at the desiderata when you're creating it and try to see if you can adhere to the points that it presents. And then of course in maintaining, if you have to maintain a terminology, the first thing you should do is find somebody else to maintain it if you can. But if you get stuck doing it, like I did with CoStar for a whole year, use principled approaches or you'll end up with a big mess. So I think I just have this last point about the national coordinators driving adoption, and there's a website for that. I think that's my last slide. So, questions?